Welcome back to the Deep Dive. Today, we're immersing ourselves in what is arguably one of the most formidable arenas in orthopedic trauma. We're talking about managing the established sequelae following proximal humerus fractures, the non-unions and the malunions that come back to our clinics with chronic pain, instability, and really profound functional loss.
This is exactly where surgical decision-making becomes extremely nuanced, isn't it? These aren't just failed fractures.
No.
They represent a failed anatomical restoration, a failed biological capacity, or, very often both.
Absolutely. And just to frame this for you, let's start with the scale of the problem. Proximal humerus fractures, or PHFs, they're incredibly common.
Well, they are. About 5 to 6% of all fractures we see.
But the epidemiological trend is, well, it's nothing short of alarming. We're looking at an incidence that's projected to triple over the next 3 decades.
A tripling. And that explosive growth is entirely dictated by demographics. It's the aging osteoporotic population that's driving this. If you look specifically at women over 85, the incidence rate just skyrockets to over 700 per 100,000 person years.
So with that sheer volume of fragility fractures, you're inherently feeding a huge surgical population that will eventually present with these really complex sequelae.
That's the heart of it. Well, non-operative non-union rates for minimally displaced fractures are low, maybe 1% or so.
Sure.
The real issue lies squarely with displaced fractures, and critically, with those treated with initial operative fixation that subsequently fail.
The dreaded failed ORIF.
Exactly. In complex cases, in elderly patients with poor bone quality, the complication rate following an ORIF can be, quite frankly, devastating. You're looking at rates between 30 and 40%.
30 to 40%. That transforms what should have been a single-stage recovery into this highly morbid, distinct surgical challenge.
It does. So our mission today is to cut through some of that noise, to really examine the robust data that guides our reconstruction choices.
And determine when we need to lean on biological support versus when we must, commit to mechanical replacement.
That's it.
Right then. Let's establish the foundational biological hurdle. Before we can even attempt to fix the failure, we have to understand the initial mechanism that dictates whether the humeral head even survives the injury in the first place. What is that critical biological factor? And what are the classic radiographic signs you must look for early on?
The critical biological factor is, without question, vascularity. The blood supply to the humeral head is, it's precarious. For decades, surgical teaching focused so heavily on the anterior circulation. We were fixated on the anterior circumflex artery's ascending branch, the so-called arcuate artery.
The vessel that's always at risk during a standard delta pectoral approach.
Precisely. We spent years focusing on how to get the plate in without stripping the soft tissue attachments that carried that anterior supply. But modern anatomical studies using things like microangiography have really altered our understanding.
Okay, so what have they shown?
They've revealed that the posterior humeral circumflex artery, the PHCA, actually provides the overwhelmingly dominant blood supply. We're talking approximately 64% overall.
64%. That's a fundamental paradigm shift, isn't it? If the posterior supply is so dominant, why do we still prioritize the dental pectoral approach that puts the anterior artery at risk? Is it just too convenient?
That is a brilliant question.
Yeah.
And it really speaks to surgical habit versus biological imperative. The delta pectoral approach, it offers unparalleled access and familiarity, especially for complex four-part fractures.
Sure, it's what we're all taught.
But knowing the PHCA is dominant means we have to be far more rigorous in our surgical maneuvering posteriorly.
So any technique that involves extensive posterior stripping could be compromising that main blood supply without us even realizing it.
Exactly. It might even explain why some severely displaced fractures, despite obvious anterior damage, manage to avoid a vascular necrosis, or AVN. The posterior supply must have remained intact.
So protecting the PHCA means meticulously limiting our posterolateral dissection.
Absolutely. Our focus has to be on minimizing posterior capsular disruption, being extremely careful when passing sutures or instruments, and just respecting those perforating vessels. But beyond what we do in theater, the other half of this is identifying that high-risk head ischemia on the x-rays. And that brings us to the indispensable Hertel criteria.
Right, and these were developed to move us beyond just counting fracture parts, to give us a real assessment of the biological risk.
Indeed. Hertel identified 2 key radiographic factors. If you see them, they strongly predict AVN, and they often push us towards a primary arthroplasty rather than trying to fix it.
And what are they?
First, a metaphyseal head extension of less than 8 millimeters, and second, a disrupted medial hinge.
Okay, let's delve into that. Why are those two specific measurements so predictive? What are the consequences of a short head extension and a broken medial hinge?
Well, think of the medial hinge as the critical weight-bearing column of the proximal humerus.
The calcar.
The calcar, yes. If that hinge is disrupted, the head fragment loses its mechanical support. It leads to instability and collapse, the infamous varus collapse.
And biologically?
Biologically, the vessels ascending from the metaphysis enter the head right through that junction. So short metaphyseal extension, less than 8 millimeters, means that the entire vascular pipeline into the head has been compromised or sheared off.
So you lose both structural integrity and the blood supply.
That's why it's such a strong predictor of biological failure. If we see those two elements, especially in a displaced fracture in an older patient, trying to save that joint often means you're just risking a catastrophic, time-consuming failure down the line. We should be bypassing osteosynthesis and moving directly to a replacement.
That's a critical decision point. Now, moving to the fixation itself, ORIF with locking plates was supposed to solve a lot of these issues, wasn't it?
It was. It was meant to provide stable, angular fixation. But the reality is that the data, particularly in complex geriatric cases, tells a very different story. We've already mentioned that overall complication rates can be as high as 49% if you include malunion.
And the complexity of the failures is what makes the salvage so difficult.
It is. We see a distinct cluster of failures. A vascular necrosis, linked directly to the perfusion risks we just discussed, happens in about 10% of fixed cases.
Okay.
Screw perforation into the joint, that's around 8%. That's often a result of trying to get maximum fixation in severely osteoporotic bone where the screws just cut out.
And the mechanical failure we see most frequently.
That would be the varus malunion. It's reported in up to 16% of patients.
And this collapse is particularly problematic because it happens despite the locking plates that were designed to prevent it.
Yes, usually when the medial column support is inadequate or you don't have a good calcar screw, the head just subsides into varus, and that directly correlates with poor functional outcomes, limited elevation and impingement.
So focusing on avoidance has to be the first priority. What are the clear high-risk scenarios where you should just recognize that the odds are stacked too heavily against ORIF and you should choose primary arthroplasty?
Well, the literature is getting much clearer on this. There are strong relative contraindications for ORFF, and it's less about the fracture pattern itself and more about the biological environment of the patient.
Right, the host.
We should strongly favor primary arthroplasty in elderly patients with complex 3- and 4-part displaced fractures, especially if they have associated head dislocations or severe comorbidities where healing is fundamentally compromised.
For example, patients on dialysis or with severe uncontrolled diabetes.
Exactly. In those high-risk metabolic environments, the attempt to achieve biological union is frequently doomed. So avoiding ORFF in these groups substantially decreases the risk of both biological failure, like AVN, and the subsequent mechanical failure of a varus collapse.
Because they're both linked to poor bone quality and perfusion.
Inextricably linked. In these cases where reliable union just can't be guaranteed, a single-stage, more reliable procedure, usually a reverse shoulder arthroplasty, is usually the preferable and ultimately the more cost-effective choice.
That principle of prioritizing reliability is paramount. Let's transition now from acute fixation failure to established non-unions. Specifically, what's the difference in management philosophy between humeral shaft and proximal non-unions? Humeral shaft fractures, often treated non-surgically, can still have non-union rates up to 33%.
Yes, humeral shaft non-union is a frequent challenge. Before we even talk about treatment, we must be really precise about timing and diagnosis. When do we actually transition from observing a delayed union to definitive surgical management for a true non-union?
That distinction is often blurred in practice, but the timing dictates the urgency, doesn't it?
It does. I mean, technically, you can sometimes identify non-union development as early as 6 to 8 weeks if there's just no callus at all and significant displacement.
But the strict definition?
The strict definition involved the fracture persisting for at least 9 months. Or, critically, the absence of any progressive radiographic healing for 3 straight months. Once you make that diagnosis, surgery really shouldn't be delayed beyond 6 months from the injury.
Why is that?
Because waiting longer just exacerbates atrophy, bone loss, and soft tissue contracture. It dramatically lowers your success rates.
And the surgical approach has to be tailored to the biology, hence the essential categorization, atrophic versus hypertrophic.
Exactly, and aseptic versus septic. This is foundational. A hypertrophic non-union is what we call elephant foot on an X-ray. It shows exuberant callus, but it fails to bridge the gap.
So that's a problem of mechanics. The biology is working, but it's not stable enough.
Precisely. Conversely, an atrophic non-union shows minimal or no callus. This is a problem of biology. The bone ends are often rounded, osteoporotic, lacking any capacity for healing.
Let's start with the hypertrophic type, which is the easier fix, provided we can achieve that mechanical stability.
For hypertrophic non-unions, the management is purely mechanical. We expose the site, debride the bone ends a little to expose vascularized bone, get proper alignment, and then apply a high-quality compression plate for rigid fixation.
And the key clinical takeaway here
Is that we typically avoid using autograft, BMP, or DBM. Since the biology is intact, union is achievable through stability alone. Adding costly and morbidity-inducing extras is usually unjustified.
Right. But for the atrophic non-unions, it's the complete opposite. They require significant biological enhancement no matter how stable you make the plate.
Absolutely right. The standard of care for an aseptic atrophic non-union is ORF with a compression plate, but it must be rigorously augmented by autogenous bone graft.
Usually from the iliac crest.
Yes, autograft from the iliac crest provides the three essential elements: osteoconduction, osteoinduction, and osteogenesis, the living cells.
How do you decide in your practice between the gold standard, iliac crest, and newer techniques or substitutes? What's the trade-off?
The choice often hinges on the volume you need. Iliac crest bone graft, ICBG, remains the gold standard, offering the highest concentration of osteogenic cells.
But the donor site morbidity is a real issue.
It's a significant concern: pain, sensory deficits, even fracture. This has led to the increasing use of the Reamer irrigator aspirator system, the RIA.
Which harvests from the intramedullary canal, promising to lessen that morbidity.
Precisely. The RIA can harvest enormous volumes of corticocancellous bone, sometimes 50 to 100 cubic centimeters, with much less donor site pain.
And the quality of the graft.
It might be slightly lower in terms of viable cells compared to ICBG, but the sheer volume you can get and the reduced morbidity make it highly compelling for large defects, especially in the shaft.
Okay, what about BMP or DBM? When do we favor a synthetic route?
They're excellent adjuncts, particularly in patients where donor site morbidity is absolutely prohibited, or maybe after a previous failed attempt where you need an extra boost.
But they're not a substitute for structural support.
Never. For non-unions that need mechanical scaffolding and biological stimulation, autograft, either ICBG or RIA, is still superior because it provides that essential osteogenic capacity.
Now, this is where it gets really complicated. Non-unions in patients with poor bone quality, or those presenting very late, where there's already significant structural deficiency, especially proximally.
That's the classic high-stress, low biological capacity scenario. When you're dealing with severe osteopenia, disuse atrophy, or large cortical bone defects, simple plating and cancellous grafting often won't be enough mechanically.
So what's the solution?
In these high-demand situations, augmentation with a cortical strut allograft is highly recommended.
The strut acts like an internal scaffolding, a biological buttress.
Indeed. You can place it intramedullary or against the medial humeral cortex, opposite the lateral locking plate. The key is to insert the screws through the plate, the host bone, and the strut, effectively sandwiching the host bone.
And that enhances the fixation strength.
Dramatically. It provides structural stability and helps resist that inevitable varus collapse in the proximal region.
I recall seeing some compelling data on late-presenting proximal humerus non-unions, those presenting more than 5 years after the injury, where they achieved really good outcomes.
Absolutely. A case series on these late-presenting cases, often Boileau type 3 surgical neck non-unions, highlighted the necessity of a robust strut. They used a Phylos plate with an autologous fibular strut graft, an FSG, placed intramedullary.
And the results were good.
Excellent functionally. The mean constant score improved dramatically from a debilitating 26 pre-op to a functional 72 post-op, with union in all cases.
That jump in the constant score is hugely impressive. What is it specifically that the fibular strut graft contributes in that proximal environment that makes such a difference?
The FSG is critical here because in these late cases, the humeral head fragment often has significant scalloping and bone loss. The FSG obliterates that gap, compensates for the deficient bone stock, and most importantly, provides medial structural support directly under the humeral head.
So it's a mechanical block against the shear forces.
It's the crucial mechanical block that counteracts the forces that would otherwise lead to varus collapse. It transforms a high-risk environment into a stable one.
Okay, before we move on to malunions, we must just briefly touch on septic non-unions. The presence of infection changes everything.
It demands a mandatory staged reconstruction. Step 1 is removing all hardware, extensive debridement of the non-union site to remove all necrotic tissue, and taking multiple cultures.
And often using an antibiotic cement. A systematic staging is essential. Okay, so if the biology held, but the mechanics failed in a different way, that brings us to the malunion dilemma.
Indeed. We now switch focus entirely to malunions. And while they can be asymptomatic in the very low-demand elderly patient, these deformities severely limit function in anyone remotely active. We're talking specifically about the varus malunion.
What's the kinematic disaster that a varus malunion causes? Why does it have such a profound impact on shoulder function?
A varus malunion reduces anterior elevation and abduction dramatically. When the head is consolidated in that angulated position, three things happen. First, the shaft is laterally displaced, which compromises the subacromial space, leading to impingement.
Okay.
Second, and critically, the malposition pathologically shortens the lever arm of the supraspinatus muscle. This severely affects the initiation and strength of shoulder function.
And third,
The distorted anatomy leads to premature contact between the glenoid and the humerus during motion.
so if the joint surface itself is still in good shape, no severe AVN or arthritis, a head-preserving procedure is the first-line treatment, especially for a younger patient.
Precisely. We favor things like corrective osteotomy, ostectomy, or tuberplasty. For more severe varus deformities, the surgical gold standard is the valgus osteotomy.
And the traditional approach for this is usually a closing wedge osteotomy.
Correct. Benigas and colleagues demonstrated that a valgus wedge osteotomy was a reliable treatment. They got union in all their patients with excellent or good functional scores. The closing wedge successfully restores rotator cuff tension and reestablishes the normal head inclination.
But there's a known biomechanical trade-off with the traditional closing wedge technique, isn't there?
That's the nuance we have to grasp. The classic lateral closing wedge, while it's excellent at restoring the inclination, inevitably shortens the overall humeral length.
And that shortening compromises the lever arm of the deltoid muscle.
Exactly. The major engine of forward elevation. That shortening can translate into a tangible loss of lifting power and strength, which is a big deal for demanding individuals.
So the evolution in surgical philosophy is moving towards addressing that lever arm penalty.
It is. We're seeing the adoption of a more advanced, vascular-sparing, medial open wedge osteotomy technique. This involves cutting the humerus, opening the wedge, and using a structural allograft to fill the opening and maintain length.
So the key distinction is that this approach explicitly aims to lengthen the humerus, or at least maintain its original length.
It does. It preserves the deltoid's efficiency, potentially offering superior functional outcomes in young, high-demand patients.
But it must be more technically demanding.
It is. It requires the incorporation of an allograft, which adds biological complexity, and there's a risk of non-union at the graft-host interface if stability isn't absolutely rigid. So the choice between closing and open wedge is dictated by the patient's age, bone quality, and functional expectations.
Beyond the shaft malunion, we also frequently see isolated tuberosity malunion, specifically the greater tuberosity, which can cause debilitating subacromial impingement.
A very common and highly symptomatic failure. The GT healing in malposition physically impacts the acromion during elevation. For lesser degrees of displacement, and we're talking even more than 3 millimeters in active patients, arthroscopic treatment can be very effective.
Which involves an arthroscopic tuberoplasty reshaping the malunited GT fragment.
Yes, reshaping the GT to ensure a clear pathway under the acromion. This is often combined with the standard acromioplasty. But, as you alluded to, technology is rapidly enhancing the precision of this.
Yes, I found the reference to intraoperative ultrasound guidance during tuberoplasty quite noteworthy. What's the value proposition there compared to traditional fluoroscopy?
It's a significant technical advancement because it solves the static limitation of fluoroscopy. Fluoro shows you bone, but it exposes everyone to radiation and only offers a near-static view. Intraoperative ultrasound gives you a non-radiating dynamic evaluation in real time.
So the surgeon can literally see the results of their reshaping as the joint moves.
Exactly. They can dynamically visualize the reshaped GT fragment passing under the acromion. This provides precise, immediate feedback on how much bone you need to resect.
It takes the guesswork out of it.
It does. You can control the resection to achieve mechanical freedom without over-resecting or compromising the tendon footprint. It makes the procedure safer and more effective.
That makes perfect sense. Now let's consider the pivot point. When the joint is irreversibly damaged, bone quality is poor, or the distortion is just too severe for a reliable corrective osteotomy, replacement becomes the option. And the debate has decisively shifted from hemiarthroplasty to reverse total shoulder arthroplasty.
The shift is undeniable, isn't it? Hemi for fracture was largely abandoned due to unpredictable outcomes, poor range of motion, often linked directly to tuberosity complications. The contemporary evidence now strongly supports RSA for complex 3- and 4-part fractures in the elderly.
And what does the evidence say about cost effectiveness? That's a huge metric for healthcare systems.
RSA has proven to be genuinely cost-effective compared to ORFF in patients over 65. The rationale is compelling. While the initial cost of the RSA is higher, this is overwhelmingly outweighed by the reduction in the need for costly revision surgery after the high failure rate of ORFF in this group.
Avoiding that catastrophic high morbidity failure provides the long-term economic benefit.
And the human benefit.
Let's look at the functional comparison from the meta-analyses. What are the key trade-offs we need to counsel our patients on?
Functionally, the data paints a very clear picture. Forward flexion is significantly better in the RSA group, with a mean difference of plus 9.7 degrees.
Which is often enough to reach the minimal, clinically important difference for these patients.
It is. Abduction outcomes are generally comparable between the two.
And the inevitable Achilles heel of the reverse.
External rotation. ER is significantly worse in the RSA group, a mean difference of minus 12 degrees. This trade-off reliable forward movement versus poorer external rotation is a constant factor.
But the stability of the result is persuasive.
Hugely. RSA delivers a massive 63% reduction in the rate of revision surgery compared to ORI. In the frail elderly, that is the critical determinant of long-term success.
A 63% reduction is a powerful argument. Now, let's apply RSA as a salvage procedure for an established non-union or malunion. That's a much more technically challenging environment.
It's a different surgical landscape entirely. You're dealing with fibrotic, scarred soft tissues, profound anatomical distortion, and often compromised bone stock.
And the data reflects that difficulty.
It does. While salvage RSA does achieve functional outcomes comparable to primary RSA for an acute fracture, it carries a significantly higher complication rate, around 14% in one series versus only 3 or 4% for the primary procedure.
Which brings us back to the critical role of tuberosity healing. Does it still matter in a reverse, given that the mechanism relies on the deltoid, not the cuff?
Absolutely, it still matters profoundly. Hemi failed because of unpredictable tuberosity healing. For RSA, while the deltoid is the primary elevator, tuberosity healing is still crucial.
For what specifically?
For external rotation, the absence of tuberosity healing is strongly linked to that notably restricted ER. An intact, healed greater tuberosity allows the posterior rotator cuff muscles to function and contribute to that crucial movement that the reverse design otherwise lacks.
Given the range of sequelae, from simple head necrosis to gross distortion, which classification framework should guide our decision-making in the salvage setting?
We rely heavily on the Boyle classification framework. It's the key tool. It divides sequelae into two main categories. Category 1 is intracapsular things like isolated head collapse or necrosis, where the tuberosities are generally in a good position.
And Category 2?
Category 2 is extracapsular or gross distortion. So, Type 3 non-unions, Type 4 severe malunions with varus and rotational deformity.
And historically, Category 2 sequelae were almost a contraindication for replacement.
Precisely. The historical consensus was that outcomes were universally poor if you needed to do a greater tuberosity osteotomy, which you often do to gain access or corrupt the deformity in Type 3 and 4 sequelae.
So the results were poor, with elevation limited below 90 degrees.
Yes, which led to decades of surgical caution. Many surgeons advised strongly against performing a GT osteotomy during a replacement, which forced many patients with severe deformity towards, well, less optimal solutions or just chronic pain management.
So that historical prohibition created this huge unmet need for patients with complex malunions, where the distortion is the exact thing limiting their function. The surgeon was trapped.
This is where we see the most exciting shift in the field, leveraging advanced imaging and manufacturing to bypass those limitations. The 33% complication rate reported in older series when a GT osteotomy was needed, well, that's now being systematically mitigated.
So how are surgeons tackling these most difficult sequelae, the profound type 4 malignans, while achieving reliable function and lowering those complication rates?
The answer lies in the integration of 3D technology. We're moving towards multiplanar corrective humeral osteotomies, or MCHO, combined with reverse arthroplasty, all facilitated by 3D printed patient-specific instrumentation, or PSI.
Okay, let's unpack that. MCHO and PSI are cutting-edge terms. What is the precise workflow and technical advantage this system provides?
Well, the complexity of a type 4 malignant is that the deformity is never just in one plane. It's varus, translation, and rotation. Try to correct that freehand in theaters. It's prone to error.
Sure.
The 3D planning workflow starts with a high-resolution CT scan. Then, using dedicated software, the surgeon virtually performs the complex bone cuts, the MCHO required to precisely correct all 3 planes of deformity.
So you're basically perfecting the surgery on a computer before you even step into the operating theater.
Exactly. And once you have that ideal position virtually, a 3D printed patient-specific instrumentation guide is manufactured. This guide is unique to the patient. It perfectly matches their deformed bone and has fixed slots or holes that dictate the exact orientation and depth of your cuts.
The PSI guide is translating that digital plan into a precise physical reality. That's the value proposition.
It is. The value is precision and reproducibility. The guide snaps onto the deformed humerus, ensuring the cuts are executed exactly as planned. This allows for optimal correction and prepares a perfect bone bed for the reverse stem. You're no longer guessing about the rotation or the degree of valgus needed. It's all defined beforehand.
And what functional difference does this make for these most challenging patients? The Boileau type 1C, 1D, and 4.
The results are genuinely transformative. A prospective study using this 3D-guided MCHO plus reverse technique showed a dramatic functional improvement. The mean constant score went from a pre-op mean of about 24 to a highly functional 68 points at 2 years.
And what about the MCID, the minimal clinically important difference?
It was achieved in an astonishing 95% of patients.
95%. In the most complex salvage group, that is phenomenal. What about the complication rates? Historically, we were looking at 33%.
And that is perhaps the most impressive finding. Despite the complexity, the overall postoperative complication rate was only 10%.
A reduction from 33% to 10% in the most difficult group. That is transformative for patient care. What's the fundamental mechanism? How does this 3D tech avoid the traditional failure?
The key is that the MCHO technique allows for the correction of the humeral deformity without necessarily requiring an osteotomy of the greater tuberosity, even in some type 4 cases.
Wait, so by making the multiplanar correction lower down, you preserve the integrity of that crucial tuberosity fragment, effectively bypassing the need to mobilize it.
Exactly. The historical failure was often linked to the non-union of the surgically detached tuberosity. In the MCHO-PSI approach, if the GT is healed, albeit malpositioned, the patient-specific guide can be used to preserve it during the osteotomy, and then that fragment is fixed to the prosthetic stem.
So this technological integration overcomes the severe limitations previously associated with arthroplasty in type 4 sequelae.
It does. It makes MCHO plus RSA a highly viable option for these challenging cases where function was previously unreliable. It's the ability to achieve that perfect pre-planned correction that ensures the implant sits correctly and the soft tissues are tensioned appropriately.
That is genuinely groundbreaking. So to bring this deep dive together, let's summarize the critical takeaways for clinical practice.
I think, in essence, the entire management pathway for these sequelae has to be highly structured and evidence-based. The future really hinges on early risk identification, using tools like the Hertel criteria to predict AVN risk, and then making an early definitive decision to either fix or replace.
For non-unions, we have to correctly classify them. Do we need mechanical stability for the hypertrophic type, or intensive biological augmentation with autograft, or even a fibular strut for compromised trophic bone?
And most critically, the management of malignans is moving to the technological forefront. In the elderly, primary RSA often provides a more reliable, cost-effective outcome than ORIF, specifically by mitigating that catastrophic risk of revision surgery.
And for the truly complex anatomical chaos of established type 4 sequelae, the evolution to 3D planned multiplanar corrective osteotomies with a reverse offers a promising, significantly less morbid path towards substantial restoration of function.
The ability to precisely restore anatomy in a pre-planned way fundamentally changes the biomechanics we could achieve. It offers hope for higher functional demands than we previously dared to promise in this salvage setting.
And considering those superior outcomes and the proven cost-effectiveness, how might the wider adoption of 3D planning and PSI impact our ethical obligation? If this tech reduces the complication rate of the most complex salvage procedures from 33% to 10%, are we now obligated to employ it, despite the initial higher costs? It seems we're only just scratching the surface.
That question balancing initial cost against a significant reduction in patient morbidity and lifetime healthcare expenditure is one that every orthopedic system worldwide is going to have to confront.
We hope this deep dive into proximal humerus seculae provides practical, evidence-based insights for your clinical practice. And if you found this discussion valuable, please do take a moment to rate and share the show with your colleagues.
Thank you for joining us.